Welcome to ATCM, the Emergency Medicine channel. Today let us discuss about meningitis, that is the inflammation of brain. When we talk about meningitis, we should know that it is the inflammation of covering of the brain, that is meningitis, and when there is inflammation of brain, we call it as encephalitis. So most of the patients can have meningitis or encephalitis. Some patients can have meningoencephalitis, both meninges and brain parenchyma both are involved, that is meningoencephalitis. The classical feature for meningitis is high degree fever, that is common in both meningitis and encephalitis. Headache, both conditions you can get headache, both in meningitis and encephalitis you can get headache, but many patients with encephalitis may have altered behavior, so they may not complain about headache, but whereas in meningitis most patients are having normal consciousness, so they mainly complain about headache. Neck stiffness or nuchal rigidity or neck stiffness or all are same. Patient will be unable to bend the neck, or examiner will be having difficulty in bending patient's neck, that is neck rigidity. These are the classical findings you get in meningitis. Altered behavior is a classical finding of encephalitis. Normally altered behavior will not occur in meningitis, but somebody who is having meningoencephalitis, they can have all these four findings. Now many patients with meningitis can have associated findings like high degree fever, headache, vomiting. Vomiting mostly indicates raised intracranial pressure. Altered behavior indicates brain parenchymal involvement. Cranial nerve involvement may indicate there is a focal arterial defect like vasculitis. Vasculitis may be a part of the inflammation produced by the infection. Focal deficits also can be due to vasculitis. Rashes mainly seen in meningococcemia. Neisseria meningitis or meningococcemia or meningococcal disease, they are classically present with, it's a community acquired bacterial meningitis, especially in children. They present with rashes, petechial rashes appear on body. It is mainly occurring in the trunk and lower portions of the body. Macular-papular eruptions resembling a wide variety of viral exanthems, particularly rubella, is also seen. So they have severe rashes all over the body. It may mimic any other viral disease. For example, in dengue also you get all these things. Dengue also you get rashes and encephalitis. Here also you get rashes and encephalitis. So Neisseria meningitis, you can get meningitis with skin rashes. The rashes may progress to purpura fulminans when it is usually associated with multi-organ dysfunction syndrome or shock. This is called as Waterhouse-Friderichsen syndrome. Bleeding to adrenal glands leads to adrenal failure. So in meningitis, due to meningococcemia, you can get meningitis, you can get skin rashes, and there will be bleed into the adrenal gland, and adrenal failure can occur that produces hypotension and shock. So if the patient is having meningitis with rash with hypotension, we have to always suspect Neisseria meningitis. This is mainly because this is highly contagious. This infection can spread to healthcare worker who is carrying the patient. So we have to be very careful in this type of infections. Now there are few signs which are very important in meningitis. One is Kernig sign. To elicit Kernig signs, you can flex the hip joint, then extend the knee joint. It is impossible to straighten the knee due to spasm of hamstrings. This maneuver stretches the roots of the sciatic nerve, which are inflamed at their axis from the spinal theca. So you can see the picture. Try to flex the hip, then extend the knee joint, so that patient develops severe pain on the back. That is a classical finding seen in meningitis. This is not straight leg raising test. Many think that straight leg raising test is done for meningitis. That is different. That is for sciatic root pain. That in that you don't flex the hip joint. You make the leg straight and lift the leg. Neck stiffness, you can examine the neck. For examiner can try to flex the neck. Examiner feel resistant to flex the neck, and while flexing the neck you can see the hip joint also flexes, and the same thing when we try to flex the hip joint, you can see the neck also flexes. This is called as Brudzinski's neck sign or Brudzinski's leg sign. In that, most important is stiffness for the neck flexion, that is called as nuchal rigidity, neck rigidity. This is classical for meningitis, and it also seen in patients who is having subarachnoid hemorrhage. Now, depending on the age, different organisms can be different organisms can produce meningitis. In that, most important is pneumococcus, and 50% of the infections are due to pneumococcus in adult. Neisseria meningitis 25%. Other gram-negative organisms also can be there. But remember, in extremes of age, very younger age like neonates and very elderly people, most of the time this is due to Listeria monocytogenes. Listeria is a organism which is common in patients who is having extremes of age. That we have to remember, because the antibiotic of choice in Listeria is different from pneumococcus or Neisseria meningitis. Staphylococcus can also produce meningitis, but these staphylococcal infections are mainly after neurosurgical procedure or frontal bone injury or ear injury. Like that, some altered bone structure or during the procedure or after the procedure, neurosurgical procedure, patient can develop this type of infection, mainly Staphylococcus, Pseudomonas, pneumococcus. All these infections are common after neurosurgical procedure or after head trauma or ear injury, all these things. Now, chronic meningitis is defined as meningitis progresses more than 4 weeks. The most common infection which can produce chronic meningitis in our country is TB meningitis. Then other non-infectious conditions are malignancy, sarcoidosis, Behçet's disease, vaginous granulomatosis, CNS granulomatosis, anchitis. Like that, different non-infectious causes also can produce meningitis. That produces chronic meningitis. In that, most important in our country is TB meningitis. Now, once you diagnose clinically meningitis, high degree fever, neck stiffness, altered behavior, any focal neurological deficits, we always suspect meningitis or meningoencephalitis. We have to do LP. The LP should be done in aseptic precautions. You can put the needle somewhere in between L4, L5 area. You can drain the CSF and you can investigate. Whenever you want to do CSF study, always better to, if facilities are available, always better to go for the imaging before CSF analysis, because if there is a raised ICP, you can easily pick up by imaging studies. If only CT scan is available, you can look for any raised ICP features in plain CT. If CT with contrast is available, you can see whether there is any contrast enhancement in CT. But MRI with contrast will be the better choice to pick up meningitis. MRI with contrast, you can see there is enhancement of inflamed meninges in the MRI with contrast. Even tuberculosis also, that is base of the brain enhancement you can see in tuberculosis. So MRI with contrast will be a better imaging choice than CT with contrast in meningitis. So always try to do the MRI first, then go for CSF study. When we see the CSF picture, the CSF picture will be like this. So you have to see the cell count, cell type, glucose, protein, gram stain. In that you see protein. Protein will be elevated in almost all types of inflammatory condition, whether it is viral infection, bacterial infection, tuberculosis infection, fungal infection, even in malignancy it will be slightly elevated. And it is highly elevated in bacterial infection because the inflammation is very high in bacterial meningitis. Whereas glucose is reduced in almost all conditions except in viral infection. Viral infection, glucose is not reduced because other bacteria, mainly bacteria and fungal infection, whether it is tuberculosis or some other bacteria and fungal infection, they utilize the sugar in the CSF, but whereas virus will not do that. So viral infection, mostly CSF glucose will be normal. Cell counts are highly elevated in bacterial meningitis. It is mostly neutrophilic elevation, whereas in TB and other conditions, TB, viral or fungal malignancy, all these things, lymphocytes are elevated. So the most important condition where there is elevation of the neutrophil is bacterial meningitis. But remember, a bacterial meningitis after few days, so after initial treatment, the neutrophils may change to lymphocytes. So that is very, very important, because if you are treating a partially treated meningitis, the patient has received already antibiotic somewhere else and is coming to your hospital when you are doing LP, and if it is more predominantly lymphocytes, it may be due to a partially treated meningitis. The neutrophils have changed to lymphocyte. Like that, in tuberculosis and viral, high inflammation in the initial stage can be even neutrophils. So there are exceptions for all these values. Some conditions you can have you can have a completely reverse picture of the cells, what is given here. So we have to be very careful. Whatever it is, when we are treating patients clinically, most of the time the picture of CSF study will be like this. Gram stain will be positive mostly in bacterial infection, that will be negative in other type of infection. AFB stain will be positive in TB meningitis. TB PCR can be positive, or gene expert can be positive in TB meningitis. Malignant cells can be positive in malignancy induced meningitis. KH smear or a fungal smear, India ink preparation, all these things can be positive in fungal meningitis. Now, once you make a diagnosis of meningitis, you have to always treat. We will not wait for the culture report of CSF. We have to treat the patient because it's a medical emergency. If you don't treat, patient may develop raised ICP, obstructive hydrocephalus, seizures, all these things. So it is better to treat the patient as soon as possible. So whenever you suspect bacterial meningitis, community acquired bacterial meningitis, basic idea is to cover this patient with two important antibiotics. One covers gram positive, one covers gram negative. So for that, we usually prefer vancomycin with ceftriaxone combination. We usually give vancomycin with ceftriaxone combination. You can see the dose here. 15 to 20 milligram per kg body weight. IV TID is the dose of vancomycin. Ceftriaxone, you can give 2 gram IV BD. Meropenem, if you are preferring, then 2 gram IV TID. So these are the usual drugs. Vancomycin with ceftriaxone, vancomycin with meropenem. Meropenem will not cover MRSA, that's why we are giving meropenem with vancomycin. But if the patients are in extremes of age, like patient is having meningitis in age of 75 or 80, that is an extreme age, or very young child, then listeria should be suspected. We have to give ampicillin. So ampicillin is the drug of choice there. And in a hospital acquired infection, again vancomycin with meropenem will be a choice. So these are the usual empirical antibiotics. Most of the time, when we start antibiotics, when we have a meningoencephalitis, we also add acyclovir. Acyclovir is an antiviral drug which can be acted against, which can be used against HSV1. Remember, it is only useful against HSV1. If you are ruling out HSV1, then there is no point in continuing that. And some areas like endemic malaria area, patient coming with encephalitis or meningitis, the malaria also should be treated initially. You can start antimalarials also. So initially it will be a cocktail type of therapy in emergency room. Once you make a proper diagnosis after LP study, you can remove the unwanted drugs. Okay. So initially it will be an empirical cocktail therapy. Then you can go for specific treatment. Where malaria is not an endemic area, no need to give malarial anti-malaria drug. Where the patient is not having any altered behavior, no need to give antiviral drug. So when the patient is having meningitis with altered behavior, it will be very difficult. Sometimes it can be a toxicological case. So we have to be very careful when we are treating with patients who is having altered behavior. Altered behavior, the reasons are multiple, but meningitis, the reasons are very few. you can get when the patient is having neck stiffness and headache, the reasons are very few. Either it is meningitis or subarachnoid hemorrhage. After doing a MRI or CT, you can rule out subarachnoid hemorrhage. Now, steroids are another important drug in meningitis. If the patient is having an infection with capsulated organism like streptococcal pneumonia, then if we treat the patient with antibiotic, the capsulated organs, that capsules, the covering of the bacteria, can produce acute inflammation after the death of the bacteria. It can produce acute inflammation in the CSF. To prevent that, at least half an hour prior to the first antibiotic dose, we have to give dexamethasone. Dexamethasone got a better penetration than any other steroids in to inflamed meninges. So dexamethasone 8 mg can be given, then antibiotic can be started. So if there is no capsulated organism, if you are ruling out pneumococcal pneumonia, streptococcal infection in the CSF, then you can possibly remove that dexamethasone. So gram-positive cocci, if it is present in the CSF, we have to continue dexamethasone. Like that, if the CSF shows in CSF study shows TB meningitis, you have to continue steroids. Their steroids are used for different purpose, because TB mostly it can produce adhesions in the area wherever there is infected. In brain, it can produce obstructive hydrocephalus. So to prevent that, we will have to give steroids. There the steroid has to be continued for a longer period, but in streptococcal pneumonia or staphylococcus infection, it can be a short duration of steroids. That is just to prevent the capsule induced toxicity or reaction in the CSF. So we have discussed about one of the important infections in emergency room, and that is meningitis. Depending on the age, you have different organism, but when we are treating adult, it is mostly due to a gram-positive cocci. Even when we know that it is gram-positive cocci, when we are treating the patient, always an empirical treatment which can cover both gram-positive and gram-negative organism. That's why we start vancomycin with ceftriaxone. So any patients who is having meningitis, before starting antibiotic, we have to give dexamethasone. Dexamethasone is given to prevent the immune reactions produced by the covering of the bacteria, that is mainly used in capsulated organism like streptococcus or staphylococcus. It can be stopped once your gram stain is negative for that. Then in TB, steroids has to be continued to prevent obstructive hydrocephalus. Some patients who is having meningitis can have focal neurological deficits like cranial nerve involvement, seizures, stroke-like features. These are all due to vasculitis. There also you have to continue steroids because it's an inflammatory reaction which is occurring in the blood vessels. If you don't treat, it will be like a stroke. The damage can become permanent. So there also you have to continue steroids. Otherwise, steroids in meningitis, in a normal meningitis, does not have any role. Other things in ICU, we have to be very careful. We have to give heparin to prevent deep vein thrombosis. We have to catheterize the patient if the patient is unable to go to bathrooms. If the patient develops seizures, we have to give anti-seizure medications. If the patient is having infections like malaria, or if there is a hepatitis, to prevent hypoglycemia, you have to give continuous dextrose infusion. So other things also have to be taken care properly in ICU. Thank you.